beginning by these lectures on the routine issue, which are cystic neoplasm. This is my disclosures. So, as you know, cystic lesion, it's really an epidemic, and we have now the last figures obtained in this meta-analysis published in 2024, which means that the numbers of cystic pancreatic lesion, it's the double that what we were thinking 5 years ago. If you look at it, at between 50 and 60 years, you have around 10% of the overall population, and after 80 years old, you have around 50% of the population which has cystic lesion. The prevalence is the same whatever you use MRI, low Tesla or high Tesla, and of course it depends on the radiologist. When these charts are the standard charts, they found 5% of cystic neoplasm, but when it's an independent radiologist, it's 25%. 80% of all these lesions are neoplasm. And the neoplasm, the main neoplasm is IPMN, and the second one, and this the reason why we have so much issues and so much concern in this lesion is serous cystadenoma. And serous cystadenoma, so it's frequent, and it's totally benign, and it's the differential diagnosis of this serous cystadenoma make that we have issues in outcomes of these lesions. So you see, you know everything about this risk of malignant transformation, but we will see that it's more difficult than this. So when imaging is typical, there is no need for sampling. Mucinous cystadenoma, for example, when it's typical, you know it's mainly women, it's mainly body and tail. You know that this mucinous cystadenoma, in fact, is an embryological abnormality in women, which is like ectopic pancreas into the antrum. It's ovary inside at the level of the posterior and inferior part of the body of the pancreas in the majority of the cases. Okay, and of course, you have a risk of malignancy. When you have this kind of imaging, you do not need any sampling. You have to give the patient to surgery, or if you do not believe that this lesion will move to the cystadenocarcinoma. And some of the teams in the world, they think that we can follow these ladies when it's 3 centimeters. For me, it's totally crazy because the ladies disappeared 10 years after the beginning of the follow-up and came back 20 years later with a cystadenocarcinoma. So, of course, the majority of the teams operate this kind of lesion. So, it's not easy for serous cystadenoma. Of course, everybody thinks that the typical aspect of serous cystadenoma, it's easy. But because now we stopped using ultrasound in the large department, we use CT, we use MRI, sometimes AUS, but no ultrasound. So this diagnosis started to be difficult during the last 10 years, but it was easy 30 years ago. Even the microcystic type was so easy 30 years ago because we are using ultrasound, and now it's difficult. But what you have to know is that the microcystic type, which is a typical type, is only 45% of the cases, which means that the macrocystic type or the mixed type, which look like mucinous lesion, IPMN or mucinous cystadenoma, is 50% of this serous cystadenoma. And serous cystadenoma is 20% of cystic neoplasm. So the results of this is that 61% of the patients with serous cystadenoma are operated on, which is not good at all. The second, of course, main cystic neoplasm is IPMN. You know all this kind of things, mainly side branch. Of course, when it's a main duct IPMN, which is obvious on CT, MR, AUS, the difference is that with AUS, you see better the mural nodules. And because of the mural nodules, sometimes they have the same density and intensity than the normal parenchyma. In fact, you can have a fantastic MRI with a dilated duct, and in one part of this main duct on the MR, you have the diameter is less big, and you think it's like this, but finally, when you do AUS, you find a mural nodule, and a big mural nodule inside the duct, which is not depicted by MRI or CT. You have to know these kind of things. This is side branch IPMN, and we think that with MRI, we have the communication with the duct, as it explained in all the meetings, in 90% or 100%. It's totally false, totally false. Patient by patient, yes, but cyst by cyst is totally false. And when we are taking care of patient, we have to know that. So MRI is not able to demonstrate a connection between the PD and the side branch in more than 50% of the case. And pseudo-connection are seen in 10%. You have this very beautiful surgical series. You have side branch IPMN operated on, and they look at all the cysts, and you have mucinous cystic neoplasm operated on. And if you look at this, the sensitivity in side branch IPMN, cyst by cyst, to discover the communication was 100%, well, 30%. And the specificity was only 90%. So, okay, so it means that it's slightly more difficult than everybody is thinking. So if we summarize the morphology of cystic neoplasm, the main differential diagnosis is macrocystic and mixed macro-microcystic variant of serous adenoma. And what you have to know is that macrocystic variant or mixed macro-microcystic variant of serous adenoma is associated with IPMN in the same patient in 20% of the cases, which means that you have a splendid IPMN and a big cyst. And the big cyst is operated on because you have an IPMN, and the surgery say serous adenoma. So you have cut the pancreas for nothing. So when it's difficult, we need sampling, but we need specific tools. The goal of this sampling is to affirm, to demonstrate formally that it's this or this lesion, not to have suspicion. But if the sensitivity of the test is low, finally, we have no use in standard practice. So we have the viscosity, the CEA, the glucose, the cytology, and we have cell visio, molecular markers, and microbiopsy. So viscosity is very, very, very good. The specificity is 100% finally, but the sensitivity is not 100%. But when you do not need any expensive tools. You have the diagnosis of mucinous lesion. The CEA is not so good, okay? When it's very low, it's suggesting serous adenoma. When it's more than 200, it's suggesting mucinous, but finally, it's really when it's more than 800 that the specificity is near 100% for mucinous, 800. Glucose is better, but the combination of both do not improve the results. So I use mainly glucose. Cytology is not good at all. These are the meta-analyses. Sensitivity 54, 63, you can say, oh, it's good. Specificity 88, 93, it's good. But finally, if you look at these studies which are inside the meta-analysis, they combine lesion with nodules and lesion without nodules. But the lesion with nodules, we do not need any sampling. We have a nodule, and we have to operate it on if the patient is good fit for surgery. So to do a cytology here has no sense. But we need cytology when you have a cyst with a thin wall, and you don't know what it is. And in that setting, it's 10% sensitivity of cytology. So cytology has no interest when you need really cytology. Molecular biology, of course, is the future. However, it's $4,000, okay? And it's very expensive. And we have so many patients with cyst that it's a big problem. So if I summarize, when you have GNAS mutation, you have IPMN, okay? You can have now very specific mutation for high-grade dysplasia or cancer. But we do not know if, at all, if this mutation are seen in patients with thin wall or mural nodule. If this mutation are seen in patients with mural nodule, no interest in practice because we have to operate the patient. If this mutation are seen in patients with a normal cyst of 3-4 centimeters with thin wall, very interesting, but we do not know at that moment this. So we are waiting.